Hello, good evening, and thank you so much for joining us this evening. Way more exciting than the World Cup for you tonight. We have our special edition webinar, Genomics in Primary Care, where over the next hour we aim to demystify genomics and clinical genetics for you and help us all to understand why this is such an important hot topic for us to understand better in primary care. Lovely to meet you. Thank you so much for giving up your time to be with us. My name's Simon Curtis, and I'm a GP, and I'm the co-founder of NB Medical and the education lead for NB Medical Education. And it's my delight and my privilege to be the main presenter tonight. But on our webinar tonight, we've also got Rob on the chat, and Rob will also be introducing us two very special guests to us. So Rob, good evening.
Good evening, Simon, and a very warm welcome from all of us this evening. We hope you have a fabulous evening tonight. Lots of really fascinating learning, really interesting area of genomics, not an area I'm very strong or familiar with, so I'm sure this will be a great learning experience from all of us. For those of you that haven't met me, my name's Rob Walker. I'm a GP down in Basingstoke. Tonight I'm going to be running the Q&A. For those of you that haven't done one of these webinars before, the live webinars, there's a Q&A tab at the bottom of your screen. Please do click that, send through any questions, comments, reflections. If you have a particular interest in genomics, please do let us know. Any thoughts on the material we're discussing, please do let us know. But we are thrilled. We've got two special guests with us this evening, as Simon has said, which really adds to the presentations and the discussions we're going to have. So I'm going to introduce them both now. We've got Iain Turnbull, who's GP and Clinical Research Fellow in Oxford, and Judith Hayward, who's a GP with special interest in clinical genetics and genomics. But I'll leave them to do a bit more of an introduction. But we're thrilled to have them, and importantly, both GPs, so they really do know and are coming from the primary care angle. So Iain, can I introduce you first, please?
Yeah, thanks, Rob. I'm Iain Turnbull. I'm a GP, first and foremost, but I'm also a Clinical Research Fellow in Population Health in Oxford, and also the Deputy Chief Medical Officer at Our Future Health, which we'll learn a little bit more about later on in the presentation.
Thank you very much, Iain. And can I introduce Jude next?
Hello, thank you very much, Rob, and thank you very much, Rob and Simon, for having us on today. I'm Judith Hayward. I'm a GP in Bradford and have been a GP in inner city Bradford now for over 20 years. I'm a GPER in clinical genetics, and this has led me to have a long-standing interest really in education and implementation of genomics within primary care. So I also have a role as National Primary Care Lead for the Genomics Education Programme. I'm clinical representative for genomic medicine for the RCGP, jointly with a colleague Imran Rafi, and I'm also principal clinician for primary care for Genomics England. Thank you.
Great. Thanks very much, Jude. Thanks very much, Iain. And so do keep Rob. Thank you very much, Rob. So do keep Rob busy on the chat, firing in your questions, your thoughts, your comments this evening. And before we start, just if you're new to us at NB Medical, just a very quick plug for all of our Hot Topics courses that a brilliant team of GP educators bring to you. We've got a full range of full-day courses, half-day courses that you can do live and interactive, or you can do on demand, or you can subscribe to NB Plus, where you can get all of the CPD you could ever need, all of our material pre-recorded, available to access at any time, also to access all of our course reference books, our appraisal essentials, our CPD learning modules, and our new AI assistant called Ask Archie, named after Archie Cochrane, founder of evidence-based medicine. And this Archie just mines on our material, so you can ask questions and get evidence-based answers that you can trust based on our material in real natural language as well. So do have a look at that. So first up, I'm going to ask you a question. So on a scale of 1 to 5, how confident do you feel about clinical genetics in primary care? Would you say 1, not at all confident, 2, mildly confident, C, pretty neutral, 4, no, I feel quite confident, or 5, very confident? So where would you put yourself on that scale, do you think, about how confident you feel about clinical genetics in the primary, how confident you're feeling? Yeah, most of us do not feel pretty confident about this. And don't worry, it's not just you, it's also me and Rob. Obviously, I feel a bit more confident now. I've done the research to present this webinar, but before that, wasn't feeling so confident. And it's something which is because genetics, genomics, we'll discuss the difference between them two, has always felt a rather sort of specialist area. And one of the key learning points we want to get across tonight is that this is really talking about mainstream clinical medicine and things that we really need to understand in primary care. And I really, really hope that this evening, at the end of the evening, we'll feel a bit more confident about this really important topic. So our plan for the next hour, I'm going to do an introductory section talking about, well, why genomics matters for primary care and a few revision points of the fundamentals. Then we'll have a bit of chat with Rob and with Iain and Jude. Then we're going to talk about a couple of high impact genetic conditions in primary care, which we really need to know about to be able to recognize. And then we're going to do a little bit of sort of future gazing, talking about things like pharmacogenetics, polygenic risk scores, what are they, direct to consumer tests, and introduce you also to this brilliant resource for further learning called Genotes, and wrap it up with at the end. So that's the plan for the next hour. And as you go through the next hour, do keep Rob busy on the chat with your questions and comments, but also note down any of your learning points as you go, and we'll share those at the end of the evening as well. So first up, why does genomics matter for primary care? Well, as you know, last year, the big NHS 10-year plan was published, and there are three big shifts which are part of this plan for the next decade. More care moving from hospital into the community, is hoping that funding will follow that. Digital transformation, and a big move from sickness to prevention. And genomics is a key part of that sickness to prevention shift, because it's this cornerstone of more predictive, more personalised and preventive care. So it's a very key part of the direction of travel for the NHS for preventative care over the next decade, and not just in a specialist settings, but becoming a much more core part of routine care, not just for rare diseases and cancers, but to be embedded across multiple clinical pathways, including for us in primary care, increased testing for single gene disorders and, for example, genes coding for drug metabolism, which we'll mention later, but also possible future integration of these polygenic risk scores, which we'll also touch on. So genomics matters now for primary care because essentially we are at the heart of clinical medicine, and we're also at the heart of family medicine. We're family doctors, that's what we do. And genomics gives us the key for better prediction of risk, stronger prevention and earlier diagnosis of conditions, and then subsequently offering more personalised treatments. So genomics fundamentally really matters for primary care, but as we've shown, most of us have got vague memories of things from medical school, but otherwise have got a really significant learning need here for us to improve our understanding or our genomics literacy. So let's have a first think, well, what actually is genomics? Is this just the same as clinical genetics? Well, genomics is actually much broader. Genomics looks at the entire genome and how multiple genes interact together. And our genome includes both genes, which are DNA, which codes for molecules, and also non-coding DNA. So the genome is the complete genetic information of an organism. So genomics is essentially incorporates genetics, but is much broader. And this is not a specialist subject, because how the genomics manifests itself is essentially in terms of how patients present to us with genetic conditions. And they reveal themselves through the conditions that patients present with and crucially with their family history. So we're not talking here about a vast chunk of new and intimidating knowledge. We're just thinking about understanding better, particularly family history and inheritance of risk of conditions. And essentially, genomics has got this sort of very big aim of thinking, well, how can this very large-scale genetic information of the whole genome improve disease risk prediction, prevention, diagnosis, and treatment? So let's have a look at a few simple revision points for us. So first, let's really go back to the basics. So, of course, we've got 46 chromosomes in each cell, arranged as 23 pairs. 22 of these pairs are autosomes of the non-sex chromosomes. So when we're talking about conditions which are autosomal recessive, autosomal dominant, we're talking about these conditions which are from the non-sex chromosomes. One pair of sex chromosomes, so when we're talking about X-linked conditions, haemophilia, for example, we're talking about conditions which are carried, genes which are carried on those chromosomes. Now, we all have completely unique DNA with multiple genetic variants. So a variant is a difference in the DNA sequence compared with a reference sequence. An important thing to understand, of course, is variation is the norm. Every person carries millions of genetic differences. So the vast majority of these variants are not harmful. They are benign or likely benign. A small proportion of these variants are pathogenic, and they used to be called, and often still are actually, mutations, these harmful variations. But when we hear the word mutation, which is actually a bit of a loaded term, we're actually talking about a variant, a variation in the DNA sequence. So let's have a think about 5 essential revision points of genomics. So firstly, autosomal and sex-linked inheritance, single gene versus polygenic disease, genotype versus phenotype, penetrance and variable expression, and epigenetic. And then we'll go to Rob and our expert guests. So firstly, autosomal dominant and autosomal recessive inheritance. So these genes are on autosomal non-sex chromosomes. And if they're autosomal dominant, then you only need one parent to have them, and then you're to have the condition. So therefore, offspring have got a 50% chance of inheriting the condition. Huntington's disease is an example. Whereas autosomal recessive, you need 2 parents with carriers, and then you may have a 1 in 4 chance of inheriting the condition. Then we have conditions which are single genes or polygenic disease. Now, single gene caused by a variant, or using the more loaded term, a mutation in a single gene. So very well-known examples of this will be haemochromatosis or cystic fibrosis, where you get a single gene that may cause a condition. And this has obviously got great potential for diagnosing these conditions, but in the future, with things like gene editing techniques come in, has also got a lot of potential therapies for genetic conditions. And then there are polygenic conditions which are influenced by many genes in the environment. So obesity, hypertension, type 2 diabetes, etc. These are also genetic conditions, but polygenetic, which is where these polygenetic risk scores may come in. So we have our genetic makeup, or the code, which is the genotype, but this a number of different factors will determine whether or not we actually have any observable characteristics of the disease, which are, of course, the phenotype. And these are dependent on a couple of different things. Firstly, variable penetrance. So if you inherit a gene for a particular condition, not everybody will inherit that condition, or there'll be variable expression of the gene, which will determine its severity. And this is also partly determined by the really fascinating area of epigenetics. So we can't do anything about the genes that we actually inherit, but epigenetics refers to the sort of biological environment which switches these genes on and off or influences how they behave. And whilst we may not be able to do anything about the genes that we've inherited for a lot of conditions, lifestyle factors, the environment that we live in, stress, aging, all of these sorts of things can turn genes on or off. This is epigenetics, and again, which has got interesting therapeutic potential in the future, which may determine whether or not that gene is expressed, and therefore whether or not it then becomes apparent in the clinical condition of the patient, in other words, their phenotype. Over to Rob. So Rob, any comments or questions coming through on the chat from what we've done so far?
Yeah, thank you, Simon. Yes, and I think just reiterating what Simon said at the beginning, that the thing that's hit me most with the research is that what we're dealing with here is good family histories, and to me, actually, genomics is sort of family history plus. Really, it's about taking a really good family history. I'm going to bring Jude in at this point. One specific question, which was very interesting, I'm sure other people will be thinking about it. They were asking about these large panels of genetic risks for various cancers, which is probably referencing the circulating tumour DNA. Jude, have you got any comments about that, and whether they're evidence-based? Is this something that's coming? Where are we with that, really?
No, thank you very much, Rob. Yeah, so ctDNA, as you say, stands for circulating tumour DNA, and it's a test. It's a blood test. It can use a blood sample looking for bits of the tumour that have been released into the circulation and looking for variants within there. There are some applications in clinical practice, but not in the way that you've just mentioned. There are a couple of applications in terms of targeted treatments for lung cancer and use there, and also for disease course monitoring in a very small number of cancers that are later in the stage. I think what the question is referring to is this recent study that's the clinical trial called the Gallery trial, which is looking at the utility of ctDNA in diagnosing a number of cancers early. Now, overall, the preliminary findings, and these are preliminary findings, are that it didn't reduce the overall survival, but it looks like it could be very useful for a certain smaller cohort of cancers where the disease stage of diagnosis was improved. But in answer to your question, this is very much in the research stage at the moment. This in terms of a cancer screening tool, it's not evidence-based enough yet, and it's not in routine clinical practice.
Thank you, Jude. And just touching a little bit more on the sort of the family histories, because yes, we're going to sort of reiterate this point quite a lot over this evening, the sort of the importance of family histories, and we were talking a little bit about that sort of offline. Have you got any other sort of comments or tips or sort of points that you'd like to make to the audience regarding family histories and the importance of that when we're thinking about genomics?
Yeah, absolutely. So, I mean, family history is really the original, the best risk assessment tool, and it's something we've been doing for decades and decades. And for us in primary care, it's still the most important way of identifying people who may either have an increased risk of an inherited condition, or even have an inherited condition themselves, or who may be at risk of certain common chronic conditions such as cancer, diabetes, cardiovascular disease, and so on. And really, as primary care practitioners, our radars are usually, we're very good at recognizing red flags, and our radars are out if we see a family history where people are younger, where there may be multiple of the same cancer diagnoses, or these are very unusual cancers, and I suppose probably very helpfully that they don't tend to be environmental cancers. So things like cervical and lung cancer with clear environmental causes, they don't really have an underlying genetic basis. So yes, so family history is still the original and the best tool for risk assessment in primary care.
Thanks, Jude. Yeah, and I think just adding to that, I think the other thing I've learned since we've been doing some of these genetic conditions on Hot Topics, and thinking particularly about Lynch syndrome, is, as Jude says, I think we're very good as GPs thinking about family history of that specific cancer, but when you're talking about family histories, is just to think a bit wider. If you do get that sniff that there might be something not quite right, ask more widely and specifically ask the patient, do you have cancers in other family members and other cancers? Because sometimes, although they might seem random initially, funnily enough, they can actually be quite important. So I think that's another useful tip. And then finally, I would just like to bring Iain in at this point as well. Simon briefly mentioned about the 10-year plan and the importance of genomics and how that may come into sort of, potentially routine practice in primary care, or at least it's going to be involved in that. Iain, have you got just a few comments or thoughts along those lines?
Yeah, sure. Thanks, Rob. The NHS 10-year plan was published last year. It really, the essence of it is it's trying to move healthcare from a reactive treatment to preventative, personalised medicine. And the way that it's envisaged this will happen is that patients' genomic information, I should say, will be used to try and identify diseases at an earlier stage so they can be treated more easily and less expensively as well. I think that's one of the main fundamentals of the 10-year plan. The aim is to use organisations like Genomics England and Our Future Health to try and carry this off by doing things. And we're going to talk about polygenic risk score later, but polygenic risk score essentially could be used for those sorts of diseases that have not single gene disorders, but are those which have multiple risk factors, multiple genetic variants associated with them, trying to find those individuals who are placed at a higher risk because of their polygenic risk score, or at a lower risk indeed. And I'll just mention Genomics England in that they are carrying out the Generation study, where they're partnering with the NHS to sequence genomes of 100,000 newborns to try and detect and treat over 200 rare conditions, genetic conditions. So it's really trying to embrace the sort of new technologies we have to try and, improve, that preventative picture.
Great, many thanks, Iain. I'll hand back to Simon now for the next section.
Thanks very much, guys. We're now going to have a look at a couple of high-impact genetic conditions that present to us in primary care. First up, let's have a think about Steve. So he's 48, he works as a decorator, he's a light smoker, he is a bit of a drinker, he drinks most nights, he's overweight, BMI of 29, but he's being seen because he's been getting increasingly short of breath on exercise over the last few years and had some recurrent chest infections. You've done some spirometry, which shows reduced ratios, some limited reversibility. Chest x-ray suggestive of some basal emphysema. He's got some really abnormal LFTs. So this is the next poll question for you. So you've diagnosed Steve with COPD, started him on inhalers, and you suspect he's probably also got some fatty liver disease. So you arrange some blood tests as well. So question is, would you also check in a Steve a serum alpha-1 antitrypsin level? A, yes, I would definitely check for that. B, no, I wouldn't be on my radar. Or C, I don't think this test is available to me. So again, don't overthink it, but we're familiar with patients like Steve, diagnosed him with COPD, bit of a smoker, younger COPD type patient, mildly abnormal liver function, but he's a bit overweight as well. So would you also check for a serum alpha-1 antitrypsin level in primary care? So let's have a look at the results. And we've got a bit of a split. Well, almost half of you say you would, which is very impressive. And about a third of us would say, well, no, we wouldn't. And another 22% saying they don't think that this test is available to you, which it should be. So alpha-1 antitrypsin deficiency is one of the most common genetic diseases, but it's very easy to miss. So keeping it very simple, alpha-1 antitrypsin is synthesized in the liver, it's released into the circulation, and it protects the lung tissue from inflammatory damage. And in alpha-1 antitrypsin deficiency, the liver either makes too little of it or produces an abnormal form that damages the liver. So it's liver and lung damage that it presents with. Lung with early onset emphysema, and liver disease as abnormal alpha-1 antitrypsin that builds up in the liver. Now, this is coded for by the SERPINA1 gene. So this picture first sight looks a little bit complicated, but in the box there in the upper left, so we've got green for a sort of normal allele. So allele is a sort of variation of a gene. So we inherit a gene for eye color, but you may have an allele for blue eyes or for brown eyes, for example. So green is normal, S has got mild deficiency, Z has got severe deficiency. So if you've got two parents that have got the severe deficiency variation of the gene, then you've got a maybe which you've basically essentially normal. So both got the normal gene, no clinical significance. Or it might be Z. Now, this is what's called a sort of co-dominant gene. Both ones count. But if you've got the NZ variant, then you're going to have a reduced level of AAT and partially reduced protection in the lung. So a slightly increased risk of lung disease, especially if you're a smoker. But you've got a 1 in 4 chance of having the ZZ variant if both parents are carriers, and you have a very low level of alpha-1 antitrypsin, greatly reduced lung protection, and a high risk of lung and liver disease. So this NZ genotype is surprisingly common, 4% of people of European ancestry. And if you've got other risk factors present, like a smoking history, then you've got a higher risk of developing clinical disease at a younger age. The ZZ genotype is much rarer, 1 in 2,500 patients, but a very high risk of disease. And so again, there's a significant chance that in our practices, we may have patients who develop COPD at a younger age who may well have this condition. So when should we suspect it? And it's really thinking about if we've got a patient with COPD or emphysema at a younger age, perhaps with a minimal or even absent smoking history, smoking significantly accelerates lung damage in this condition. Of course, if there's unexplained liver disease, and also, as Jude says, the family history is key. Is there a family history of emphysema or liver disease? So what happened then with Steve? So he's got early COPD and abnormal LFT. So this patient, we should be checking an alpha-1 antitrypsin level serum test from primary care. Is also an acute phase reactant. So do not test if the patient's got a current acute infection. May consider doing it with an accompanying CRP to see if the CRP is normal. But if they've got low AAT, then the patient should be referred for genotype. Then our next condition, I'll just think about 2 45-year-old patients who present who are tired all the time. So we've got Dave. You've done your normal tired all the time bloods, and he's come back. He's got a ferritin of 550, serum iron is 12, transferrin saturation is 65%. And you've got Lorna. Her blood's essentially also normal, but her ferritin is 750, iron 32, transferrin saturation 35%. So which of these two patients do you think is more likely to have iron overload due to genetic haemochromatosis? Dave, with his ferritin of 550, iron 12, transferrin saturation 65%, or Lorna, ferritin 750, serum iron 32, transferrin saturation 35%. So which of these patients do you think is more likely to have iron overload due to genetic haemochromatosis? Right, now let's go and have a look at your answers. And yeah, bit of a split, but 70% of you think that Dave, even though he's got the lower ferritin with the higher transferrin saturation of 65%, 30% of us think Lorna with the higher level of ferritin. The 70% are right. The key thing here is the higher transferrin saturation ratio in terms of identifying patients with possible genetic haemochromatosis. And this is a really key learning point of this fantastic paper, which actually our two guests tonight, Jude and Iain, were two of the co-authors on this paper. And if you were on one of our Hot Topics courses a couple of years ago, you may have heard us talking about this paper. And it was so useful because seeing raised ferritin in primary care is such a common conundrum because there are so many of these possible causes of having a raised ferritin in primary care. But actually, true iron overload or haemochromatosis is the cause in only 10% of cases of raised ferritin in primary care. And yet it is really critically important to diagnose. And the transferrin saturation ratio is the key discriminatory test. And I think this is the most useful learning points I've had is from this paper. So if the TSAT is less than 45%, iron overload is very unlikely. So we should really be thinking about one of these other possible causes of ferritin, including possible red flags, for example. If the TSAT is more than 45%, this is suggestive of iron overload, and this patient should be having genetic testing for genetic haemochromatosis in primary care. So genetic haemochromatosis is the most common inherited condition caused by a single gene variant affecting 1 in 150 people in Northern Europe. And yet it is very easy to miss, as this BMJ paper pointed out a number of years ago, as a diagnosis. And that's because you get this very slow and insidious onset of symptoms. And I have got a personal interest in this particular topic because a couple of years ago, very embarrassed and very apologetically, I went to see my own GP saying, I feel tired all the time, very apologetic, and assuming that I may be iron deficient. And actually it then came back that my ferritin was 850, TSAT was very high, and ended up being diagnosed with genetic haemochromatosis. And what I discovered is that iron overload can become very symptomatic even before you've got evidence of significant organ iron deposition. And we've learned this over the last few years, haven't we, that iron deficiency can be symptomatic before you get clinical anemia. Iron overload can also be symptomatic in terms of fatigue, cognitive problems, arthralgia, etc. Now, this is a very good example of a gene where there is variable penetrance. So it may present in early adulthood with significant organ deposition of iron, or it may present much, much later in life. And women do tend to present much later because of the protective effect of blood loss through iron loss through menstruation and pregnancy. But then once you've got the clinical iron overload, of course, it can affect all of these possible organs, tends to, of course, predominantly affect the liver. Iron overload first affects the liver, causing significant liver disease. And this is something which is so easily preventable if we can diagnose it in an early stage. And of course, we all remember the other things from medical school, bronze diabetes and arthralgia, possibly endocrine causes, hypopituitarism, hypogonadism, osteoporosis. All of these things can eventually happen in haemochromatosis, hence the critical importance of making an early clinical diagnosis when it can be treated before the deposition occurs. So the genetics of hereditary or genetic haemochromatosis are then pretty straightforward. So in this infographic here, so the green is you've got a normal allele. C is for the common mutation, which is C282Y for the haemochromatosis. So if you've got two parents who are both carriers, they haven't got the clinical manifestation, then you have got a 1 in 4 chance, the red one, of inheriting one of these genes from both patients, being homozygous, most commonly for C282Y, although there are other genes when you've got a significantly increased risk of absorption and iron overload, and this is clinically significant. So you test Dave for HFE genotyping in primary care, which absolutely should be a primary care test. We know that there's variable availability of these tests, but it should be available in primary care. And he's C282Y homozygous, so you should refer him to hepatology for regular therapeutic venesection to get that ferritin low. And in the meantime, strongly advise him to cut down or preferably stop alcohol altogether, because just as small amounts of smoking can accelerate lung disease and F1 antitrypsin deficiency, small amounts of alcohol contribute significantly to the stress in the liver and the risk of developing hepatic fibrosis in haemochromatosis. And of course, siblings have a 1 in 4 chance of having the disease, so cascade testing as well. So those are an example of 2 very important single gene conditions to think about, but just as an example of others that we need to think about and mostly identified through family history. Family hypercholesterolemia is a great example of where we can make a really big impact with statins at a young age, which can massively improve people's life expectancy with FH. Asking about a family history of sudden cardiac death is really important to identify conditions where we might identify one on ECG, such as hypertrophic cardiomyopathy or Brugada or Marfan syndromes, hemoglobinopathy. Lynch syndrome we've talked about, not just thinking, we tend to think of Lynch when there's an early family history of colorectal cancer, but of course it also gives you a very increased risk of gynecological cancers, especially endometrial cancers, and increases your risk of other cancers, GI cancers, biliary cancers, pancreatic cancers. So when there's a number of different cancers affecting different generations of the same family, it's definitely something to think about. Polycystic kidney disease, autosomal dominant, factor V thrombophilia when there's a case of a relatively unexplained venous thromboembolism. All of these are examples of conditions that we come across all the time in primary care where we should be thinking, could there be an underlying genetic condition? Okay, Rob, over to you, Iain and Jude.
You mentioned one question that's come in, a delegate quite rightly asking about the CYP2C19 testing following strokes. We're going to cover that in the next section when we talk about pharmacogenetics. So I'll just pause that question for next time. I just want to reflect back really sort of comments from delegates, which we get often on Hot Topics courses in terms of access to testing. Alpha-1 antitrypsin, I do have access in my area. And funnily enough, actually, I had a patient that went through a rapid diagnostic clinic recently, had the CT chest abdo-pelvis, was picked up to have incidental bronchiectasis, and it was recommended to have an alpha-1 antitrypsin test in the GP surgery. It was negative. Others saying they're struggling to get hold of that one. A specific question here about where do I access transferrin levels? And I'm going to bring Jude in on that in just a second. So, yeah, Jude, can I just bring in you on 2 points there? One, you quite rightly, we were talking about transferrin saturations as a key test for haemochromatosis. Some people saying they may or may not be able to get hold of it. A, just to think more widely about where you can access that in your panels. And then B, a more specific question about family history of haemochromatosis. Somebody who's had a patient with family of history of haemochromatosis, normal ferritin and iron studies several years ago, but do they need to be retested periodically? So can I bring you in on those 2 questions, Jude?
Yeah, thank you very much, Robin. Thank you very much for the questions. So in answer to the first one, depending on the pathology system, some may list transferrin saturation or TSAT as a specific test, but others it may sit within another panel. So it may sit within something called iron studies or similar. So, and certainly where I work in Yorkshire, it sits within iron studies. So it's just worth looking, through your system to see if there's anywhere else. Regarding the family history, I think that brings up a really interesting question. I think with a family history, I don't think I would be, if somebody just had a family history, but there hadn't been any genotyping, I don't think I would be offering regular ferritin. Because I think, Simon alluded this to in the slides, the carrier frequency is very high. But actually the penetrance is certainly in some genotypes is actually much, much lower. So indications for testing when people are unaffected would be if they've got a first degree relative, so essentially a sibling or a parent that's affected. And I would suggest that offering them genotyping first, really, to see whether they actually have haemochromatosis. And then I would base the decision as to how often and whether to do regular ferritin levels on that, really, rather than solely the family history.
Thank you, Jude. And just very briefly as well, I think it might just be worth touching on the issue of referral to clinical genetics, because we've sort of casually said here with this last case, refer to clinical genetics. We were talking about access to that, but just briefly to sort of summarise what we were talking about off air about the importance of the fact we do have primary care representation and that clinical genetic clinics do have sort of linked up systems to try and make sure that information is shared as as quickly as possible to try and make life easier for us as GPs, although we do appreciate that there are long waits in some cases.
Yeah, exactly. So I think this covers the point really that families are now often geographically spread. You know, some families, extended families, may live quite close to each other, but it's a reasonably common scenario that different members of a family may be referred to different clinical genetic services. But they do have very robust systems for exchanging information. Whenever a patient or whenever somebody is offered genetic testing or genomic testing within the clinical genetic service, permission is always taken within that conversation for those results to be shared with family members. So if somebody comes to us in primary care with a family history, particularly if it's a diagnosed condition or a known gene variant, it's really helpful if in primary care we can actually include in the letter the details of the relative. Obviously, this is third-party information, but because it's come from the patient and not the relative's medical record, it's not breaking confidentiality. And quite often, clinical genetic services will also give a letter to their patients for them to give to family members. And this will have a family reference number there as well. So if the patient has one of those, it's really helpful to put that in the referral letter too. It just speeds up the flow of information and means that any relevant results tend to be there for the first appointment in clinical genetics.
Many thanks, Jude. Simon, I think I'll hand back to you for the final section.
Thanks very much, Rob. So we're going to have a quick look at some of these more future-gazing things. And someone was asking about testing CYP2C19 testing. So what is that? Well, of course, genetic variations obviously impact absorption and metabolism of drugs. We're very used to some patients having significant side effects from medications, and your next patient on the same medication doesn't have any problems with it at all. And a lot of this is due to these genetic variations. And multiple genes have now been identified for the metabolism for a whole range of drugs, including chemotherapy, proton pump inhibitors, tricyclics, NSAIDs, opioids, statins, etc., which opens up really exciting possibilities for improving therapeutics and providing much more personalised prescribing. And this is very much a focus of the 10-year plan. At the moment, there is one big example which is now we need to be aware of, which relates to clopidogrel following this NICE guideline published a couple of years ago. So as you remember, clopidogrel is a prodrug that's metabolized to its active form, and it's metabolized by this enzyme coded for by this CYP gene. Now, there are variants of this gene, so-called loss of function alleles, which lead to decreased metabolism to the active form, and this leads to clopidogrel resistance, which is more prominent actually in some ethnic groups, particularly from South Asian populations. And in patients that have these genetic variants, there's an evidence of increased risk of stroke because they're taking this clopidogrel, which for them is less effective. So NICE introduces real landmark guidance, which is the first guidance really bringing mainstream pharmacogenetics into mainstream care, which is to advise testing for these variants after a TIA or ischemic stroke. There's a test which should be done in secondary care, which we need to be aware of for clopidogrel resistance. And to help with our understanding of this, the RCGP have produced a position statement which was published a few months ago, which I'd really recommend having a look at online, which just explains about how we should understand and interpret these tests. Next up, we have these polygenic risk scores. So as we said at the beginning, there are single gene disorders and polygenic. Polygenic affects multiple conditions, diabetes, hypertension, obesity, multiple different forms of cancers. What happens here is each individual variant may have a small effect on risk, but by looking at all of these variants together, they add up to a cumulative risk, which we may be able to predict by looking at all of these different risks. Not yet in widespread clinical NHS use, but again, as talked about in the 10-year plan, and may be a key part of our clinical predictive work in the near future. So a couple of clinical examples are sort of adding in a polygenic risk score into Q risk. So we're all very familiar with Q risk for predicting cardiovascular disease risk and then influencing our decision on whether to prescribe statins or not. And there's been research about integrating polygenic risk scores into that. There's ongoing research into looking at that for helping to identify patients' risk of prostate cancer, etc. And the UK NHS, our Future Health Project, is a big research project which is ongoing, which Iain will talk about briefly in a minute when we get back to Rob, which is also looking at this risk information across 5 million people across the UK at the moment. And then what to do when we get a patient coming to see us with a genetic test which they've done privately, they've found it online. Companies, this is becoming a massive market, first in the States and now here, of companies providing direct-to-consumer genetic tests. And if you haven't already, we're increasingly likely to be asked about them with patients coming to see us with these test results. So a patient comes in saying, I've had this direct-to-consumer test, I've got an increased risk of this condition, so I want to have that scan or be referred to this specialist. So how should we manage these consultations? Well, again, about 9 months ago, the RCG produced a really useful position statement on this, giving us clear guidance as to how we should manage these consultations. First up, we should not take them at face value because we can't be assured of the quality or shouldn't be expected to interpret these results. And patients presenting with these tests should receive the same NHS care as those who have not had them. In other words, on the basis of their family history and the clinical information we would normally have. And they should not affect access to treatment that is not commissioned for that indication of the NHS. So this gives us very clear guidance as to how we should manage those, what could be quite tricky consultations. And for further learning and point of care guidance, I want to introduce you to the brilliant resource which we've discovered in preparing for this webinar called Genotes. And I'm going to hand over now to Jude to talk us through.
Thank you very much, Simon. And thank you very much for just giving me the opportunity to flag Genotes. So Genotes is a resource that we've been developing for a few years now within the National Genomics Education Programme. It's a 2-layer resource. One layer is called In the Clinic, and these resources are very brief, very scenario-based, designed to be readable within a minute or two and usable within the consultation. And then underpinning those, there's a deeper tier 2 knowledge hub, which essentially is a sort of repository of it's a summary of a subject and it's a repository of lots of resources. So we actually started to develop Genotes really in response to primary care needs around education. I've just actually put another slide there. There is a QR code there, and also the website is there as well. We have, I think, 28 resources live at the moment, with more coming on over the coming months. So apologies if you didn't get that, but I'm just going to move on. So there's a few screenshots here just to give you an idea. Genotes is actually a multi-specialty resource, but we have a primary care working group. This consists of GPs and actually pharmacists. I need to update that slide. So it's written for primary care by primary care, essentially, with peer and expert review when we need it. The resources that we've written, we've been really pleased with the user testing. The industry average you'll see there, but ours is over 90%. And so the people that use it do seem to really value it. We are trying to work to make this more visible, and we are working very closely with Ardens, who have been incredibly supportive in terms of interfacing with their templates as well. So in the middle, you'll see a list of some of the topics that we've got there, and hopefully you'll agree they are scenarios which present to primary care. And on the left-hand side, there's a content plan. So it just gives you an idea. These in the clinic resources, they're very brief, at a glance, few key points, something not to miss, and then a what should you do next. And then if you do want more resources, either for yourself or for the patient in front of you, or you want to look into it further, then you can scroll further down and then click through some of the hyperlinks. But the idea is that it's very concise, and I say easily digestible and readable in the consultation. And we've had a lot of feedback that people use these for training resources as well, because they're very closely mapped to the RCGP curriculum as well. Thank you very much, Simon.
Okay, thanks very much, Jude. So I'd highly recommend that sort of resources for sort of actual in the clinic learning as well as learning more about it. I also now want to just quickly bring in Iain, just to make a comment or two about polygenic risk scores before we go to Rob.
Oh, thanks, Simon. First thing I will say is that Our Future Health is not part of the NHS. We're just sort of affiliated with the NHS, but we're not a clinical organisation, just to make that clear. We're a research organisation with strong links to the NHS, but it's not all the same. So polygenic risk score, as you mentioned earlier, Simon, it's a means of trying to understand someone's risk based on hundreds of different what we call single nucleotide polymorphisms, or SNPs, which are these variants that we've referred to earlier. And essentially, you look at all of them in total, and some of those will be, confer a risk on an individual, and some of those will confer a benefit on an individual in terms of their overall risk of developing, let's say, these polygenic disorders like cardiovascular disease or type 2 diabetes or atrial fibrillation, just to bring up one of the questions in the chat. And as you mentioned, these are not being used in clinical care at the moment, but there are real strides to try and improve the data in this area. So what you really need to be able to do is to have large numbers of patients in large randomized trials, so we can understand a little bit better how adding a PRS to your traditional risk factors for, say, CVD helps to discriminate an individual above or below the line, say for cardiovascular disease, where you might initiate a statin to prevent someone from, or to try and prevent someone from going on to develop cardiovascular disease or something which potentially could be catastrophic. And that's why it's such a key part of the NHS 10-year plan. So yes, as I said, it's really a case of trying to build up the evidence to come to that point where you can say that it has clinical utility. So a little bit of work to go there, but hopefully with the 10-year and with organisations like Our Future Health and Genomics England, we can sort of push towards actually making it a reality in clinical care.
Great.
And just to address your question, polygenic risk score is sometimes called PGS as well, so polygenic score, but that's essentially the two acronyms for the same thing.
Okay, thanks very much. Thanks very much, Iain. And it's going to be really exciting to see how this does evolve over the next decade. Shorter time period than that, I'm sure that we'll be using these things, but really exciting to sort of look and see how this is going to develop. So before I go back to sort of Rob, to sort of wrapping up, so just to sort of conclusion, so genomics is a key part of the NHS 10-year plan as we move to delivering more personalised and preventive care. It's already part of routine primary care, but it's going to become much more so over the next 10 years. So we need to recognise these high-impact genetic conditions in primary care, single gene conditions. We've referenced alpha-1 antitrypsin deficiency, haemochromatosis, Lynch syndrome, BRCA, etc. But family history remains absolutely key in terms of identifying these conditions. Pharmacogenetics is already here with clopidogrel resistance, but it's going to become increasingly routine part of future prescribing. Polygenic risk scores, now we understand what these mean. They're not yet in NHS clinical use, but think of them as being a bit like a sort of Q risk score, including genetic information, but they're subject to extensive research and will become part of this prevention agenda. And with patients presenting with direct consumer tests, a tricky consultation, but we've got this very clear guidance from the RCGP, which is super useful, about not letting it influence the normal NHS care that you would prescribe. And for further learning or for help in the consultation when you're thinking about a genetic condition, then definitely have a look at GeneNotes. Over to you, Rob, for any closing comments or questions. And we'll also get a couple of closing comments or questions also coming in from Jude and Iain.
Yeah, many thanks, Simon. Yes, lots of really fascinating areas, and just reflection from a colleague here who was working in Australia a few years back, who already had access to genomic testing for optimal antidepressant and painkillers, and so presumably very much pharmacogenetics at sort of cutting edge when he was working as a GP, which is really fascinating. One particular question here asked by a colleague had a number of patients been asking her about APO genotype testing for risk of Alzheimer's. I think this really highlights where we have to be really careful as GPs. There are a million tests out there that people can access online, and when they're taken out of context and patients don't get adequate counselling, we need to be really, really careful. There's a real risk with something like these genotype testing for Alzheimer's. Yes, they may have the genetic variant, but that does not mean they're going to go on and get Alzheimer's disease. And the two are often not very well explained. And interestingly, I just had a quick look at the Alzheimer's Society that they would recommend that these sorts of genetic testing for Alzheimer's disease are only done as part of a research project to make sure patients are properly counselled on it. So yes, I think people need to be really, really careful about that. Yes, I'd like to just bring in Jude again, touching about the pharmacogenetics, clopidogrel genetics that was in the NICE guideline. I don't think many of us have really seen that in practice yet, but Jude, can you just expand a bit more? There's a couple of people asking about clopidogrel genetic testing, plate and antiplatelet agents, and where we may or may not be going in that sphere.
Yes, thank you very much, Rob. So CYP2C19 genetic testing, Simon, you've already alluded to. The NICE guidance makes recommendations for CYP2C19 genotyping in the setting of acute stroke. I think we're all aware that clopidogrel, that's not the only indication for clopidogrel. So there is probably a gap that we can be familiar with where there is a sort of lag between the implementation and the delivery. Having said that, there have been several pilot projects across the UK looking at how to implement CYP2C19 testing in the context of acute stroke and then tailoring clopidogrel prescription. These have now wound up and the findings have only very recently been reported, so these are being considered by NHS England at the moment. Some hospitals have actually bought their own point of care testing machines, so available, but essentially it just speaks to the fact that implementation is not yet widespread, although it is being very closely considered at the moment. There was a very specific question about clopidogrel genetic testing in double platelet therapy after stents. I would signpost to you actually this was some very recently published UK guidance under the CERSI called the Centre for Excellence in Regulatory and Science. And there is a CERSI around pharmacogenomics. They've just published UK guidance. But again, the implementation is still a step behind, and CYP2C19 genetic testing itself isn't actually routinely available in the NHS yet.
Many thanks, Jude. And finally, Iain, are there any other sort of final comments, any of the questions or comments that have come up thus far that you wanted to add to anything further before we wrap up with Simon?
There's a recent question right at the top. I'm not sure if the questioner means LP(a) or whether they're referring to a different protein, the lipoprotein. And I'm just interested to know what they mean. If they're talking about LP(a), that's not really in the genomics area, but it's certainly something that is becoming more available. Something with my research hat on, something that's causing a lot of excitement. But no, I don't really, other than to say that in terms of the data and the linkage of data available to researchers now, it becomes so much easier to be able to test some of these sort of the scientific principles, and therefore be in a better position to implement some of the things we've been talking about this evening, particularly in terms of pharmacogenomics, for example, where having access to, huge amounts of data on pharmacogenomic variants linked to the primary care data set, it really does open up things incredibly.
Many thanks. Yeah, okay. Many thanks, Iain and Jude, for all your comments. Yes, I'll just sort of briefly wrap up. I mean, it's lots of fascinating areas. I think for me, the two that really stand out are the pharmacogenetic, which I really think is going to become part of general practice over the next sort of 10 to 15 years, and the polygenic risk scores. The Transform trial that we very briefly mentioned, looking at various testing options, including PSA testing, MRI, but also the polygenic risk score. We're going to have those results within a few years to help guide, future potential screening strategies for prostate cancer. So it really is going to become part of what we're dealing with in general practice, in the near future. But I think, again, take home point for me, good family history. If we can take good family history at the very beginning, that can really help set us on our way in terms of having to fit in the genomic side of things as well. Simon, I'll just hand back to you just to finish off.
Yes, indeed. Thank you. Thank you very much, Rob, for handling the chat. Iain, I see you want to make one final point about haemochromatosis very quickly before we finish.
I think it speaks to Rob's point really about there being some geographical variation in terms of testing for HFE genotyping, so the C282Y and the C63D variants. I think there's a lot of work to try and make these variants and that the genotyping test more geographically available. So it's democratizing the testing for haemochromatosis. So there's a huge amount of work that's going on to try and reduce those barriers in primary care.
Great. Okay. Well, thank you. Thank you very much. Very big thanks to you, Iain, for your expert input, and many thanks to you, Jude, as well for your input. Rob, thanks for managing the chat, for Daniel up in Newcastle, who's been producing the webinar for us this evening. But most of all, thank you, all of you, for giving up your evening to spend with us learning all about genomics. And we really hope that you found it a very useful experience. We'd love it if you can give us your feedback, and the certificate is available in this session for you from the menu bar. Just click that. You'll be able to download your certificate, and the feedback, and a very quick feedback form will pop up in your browser as soon as we finish now. And if you've just got an extra minute to give us your feedback, that would really help us in terms of planning these webinars for you. So thank you very much for watching. Thank you for spending the time with us. Do keep in touch with us. Do get back in touch with us by email or any other means if you have any further questions from tonight. But thank you again for your time, and we hope to see you all again soon. Good night.